Welcome to this osteocomb video course on wisdom teeth. Today's topic is nerves. Well, as an oral surgeon, one of our worries is the injury of the inferior alveolar nerve or the lingual nerve. Well, this is an image of some of the nerves that I found during my surgery. And today I will try to give you my vision of how to reduce this kind of complication. First of all, let's say that the inferior alveolar nerve, which we also can call ion, it runs the homonymous canal, and it can be more or less corticalized. And together with the artery and the vein, it forms the inferior alveolar neurovascular bundle. But an interesting aspect found by you in a paper that summarized the location of the inferior alveolar nerve in a vast population is that we have that the nerve can be positioned in 51% quite far from the apex of the roots of our wisdom tooth, and this is a good information and a nice information for the surgeon, that in 32% the nerve is going to be on the lingual aspect of the tooth. And this is another good information because we know that if we use the buccal or vestibular approach, we're going to find the soft tissue, the bone, the tooth, and then the nerve. And then we have the two issues that can frighten us, which are the buccal aspect of the nerve, which is in 16% of the cases, and fortunately and luckily in 1% just intravesicular, so in between the two roots. The lingual nerve is a marginal problem with respect to the inferior alveolar nerve, but we're going to see that we can have some problems and some issues also on this kind of nerve. And it has been studied, but it doesn't have so many applications clinically. We know that the bundle can have different diameters and it can be made of one or more fascicles. But the important thing to know is that in about 10%, but we don't know and we can't know this before our surgery, the nerve can be quite superficial, so quite coronal, just behind the second molar at about 10 millimeters behind the second molar in the soft tissue. So we have to know that that area is an area that we are going to just protect, and we can't work in that area. So what are the procedures that can give us a high risk of damage? Well, we know that we can have obviously the third molar extraction or the implant placement in the mandible. We're going to focus obviously on the wisdom teeth extraction. So the cause of the damage of the nerve can be a chemical damage due to the anesthetic, and we will see this in detail, or it can be a mechanical damage, and this can lead to neuropraxia, neurotmesis, or axonotmesis, depending on the damage of the nerve. So it can be either superficial or can be a complete cutting of the ion nerve. We can also base our diagnosis on the symptomatology of the effect on the symptomatology of this kind of lesion, and we can have paresthesia, dysesthesia, or anesthesia. The paresthesia is a little bit of numbness, and the dysesthesia is usually the worst scenario because it gives a painful sensation of the damage, and this is usually the major problem with the patient, or a complete anesthesia, so no sensation at all. And also we have to base our diagnosis and our classification of the effect on a duration, so it can either be temporary or persistent or permanent. An important thing is that we have to objectivize the damage, and this is an important image that we have to do when we have a patient that has this kind of complication. So we have to map the area by probing the skin and the internal mucosa, and by drawing on the patient's face where the area is concentrated, so that we can check in time and have an objective and not a subjective information of the of how this kind of problem is going on in time, because we know that this kind of complication can have a reduction in the symptoms, which can occur in the first year. After that, there is not going to be any more recovery, and so we will have to either send the patient to the neurologist or to the maxillofacial surgeon. But the important thing to see is that if this area reduces in time, this is a very good information to know and to see, because it gives us the information that something is healing in this process. Important old information is the radiographic evaluation. We know that the panoramic X-ray is considered the gold standard of the images in the diagnosis of the wisdom teeth. And we have two very old classifications. We have the Winter classification, which gives us the inclination of the tooth. So we have the normo-inclined, the mesioangulated, the distoangulated, and the horizontal tooth. And we know that the distoangulated and the horizontal are the most complicated teeth to extract. And then we have the Pellen-Gregory classification, which gives us information on the position of the tooth regarding the ramus and the occlusal plane of the second molar. And we have the class 1, where the tooth and the crown is placed anterior to the mandibular ramus, which is the easy case, the easy extraction. The class 2, where the tooth is positioned with part of the crown which is posterior to the ramus, and part of it is anterior to the ramus. And the class 3, which is the most complicated case, where we have the tooth that is completely inside the ramus. And then we have to look on the coronal apical position of the tooth, where we have the class A, which is parallel and in exactly correspondence to the occlusal plane of the second molar, and the class B is just with a apicalization of the tooth, which is in between the occlusal plane and the CEJ, and then the worst scenario, where we have the tooth which is much more apical, which is just below completely below the CEJ of the second molar. So we know that the class C3 distoangulated tooth is the most difficult tooth to extract. But in 2018, Dr. Stacchi published an interesting classification, which is a modification of the Jubalas and Daugela classification, which was a classification present in 2016. And this gives us a risk assessment regarding the position of the tooth, and it focuses on 6 parameters. Obviously, this kind of classification and risk assessment has to be done when we have a CT scan, a CBCT, and obviously it is important for risky teeth, not for straightforward teeth. So if we just have an OPG, a panoramic X-ray, we will still use the Winter and Pell-Gregory classification, whereas if we have a CBCT, then we can apply this risk assessment classification. So we are going to give 3 points to every parameter that we are going to consider. 0 points for a conventional easy case, 1 simple, 2 moderate, 3 complicated. So let's look in detail to this classification. So the M stands for mandibular second molar relation, and it always looks at the Pell-Gregory and Winter classification. The first parameters still focus on that kind of parameters, and we have that 0 is given to the straight crown or above the equator of the second molar, 1 is given to the crown below the equator of the second molar, 2 is given to the crown or roots orientated towards the medium third of the second molar roots, and the most complicated, so we give 3 points, is the crown or roots orientated towards the apical third of the second molar, so it gives us that this is quite a good impacted tooth. Then we have a relation with the mandibular ramus, as in the Pell-Gregory, where R0 is enough space in the arch, the tooth is completely erupted, 1 is partially impacted in the ramus, 2 is completely impacted in the ramus, and 3, worst scenario, completely impacted in the ramus, disto-inclined or horizontally placed. Then we have the third parameter, which is the apico-coronal relation with the alveolar crest. 0 points given to the fully erupted tooth. 1 point given to the partially impacted with the coronal equator at the bone margin. 2 is a partially impacted with the equator apical to the bone margin. And 3, worst scenario, fully bone impacted. Then we go a little bit more in detail and we look at the mandibular canal relation, and it's the R. And we have 0 if the distance is greater between the nerve and the roots than more than 3 millimeters. But we also know that in this kind of situation, we can't exclude completely that the patient can have a temporary problem of paresthesia. Then we have 1 point given to the contact with the ion, but the canal walls are still identifiable in the X-ray. Then we have 2 points given when the contact with the ion has a non-identification of the canal walls, and the worst scenario is given to, the 3 points are given to the ion which is interradicular, so in between the roots. Then we're going to look at the cortical bone relation. So we're going to see where the roots are in correspondence to the bony buccal or lingual wall. And we have that 0 points are that the tooth is more buccal, so towards the coronal, and so we know that the nerve is going to be lingual. 1 point given to halfway between the buccal and the lingual cortical bone. 2 is going to be closer to the lingual cortical bone, and 3 is going to be closer to the lingual cortical bone, partially or completely impacted tooth. And last of all, we're going to look at the spatial relationship, so the inclination of the tooth, where 0 is a vertical, 1 is meso-inclined, 2 is disto-inclined, and 3 is either horizontal or inverted. Once we sum up the points we gave to this kind of parameters, we're going to have some numbers, and this is the risk assessment in time, duration of the surgery, and also to see if our experience and our skills are enough to challenge this kind of surgery. So we're going to have from 0 to 6 points, it's going to be a simple case. From 7 to 12, we're going to have a moderate case, and from 13 to 18, it is going to be a difficult case. So this can help us choose where we can challenge the surgery or maybe refer the surgery to an oral surgeon or a maxillofacial surgeon. But when is it necessary to ask for a CBCT? We know that we have to use the ALARA, the ALARA principle, which is as low as reasonably accepted, because we have to give the lowest dosage of X-rays to our patient. So as I said, the OPG, the panoramic X-ray, is the gold standard. But if we have one of these issues in the panoramic X-ray, as written by many authors, this is Megawa, but there are many authors talking about these kind of parameters that we have to see in the panoramic X-rays in order to ask for a second level radiograph, so a CBCT or a CT scan. So if we have a deviation or the narrowing of the alveolar canal, if we have a radiotransparency of the radicular block, or a radicular construction, or the radiopaic lines of the bony canal walls are interrupted, then it's mandatory to ask for a CBCT scan in order to have a good planning of the surgery, and also in order to reduce any problems of medical legal problems after our surgery. But what does the literature tell us? That the CT examination, yes, it gives us the possibility to plan the surgery in detail or minimize the surgery nerve trauma. But on the right side of our slide, we see that the incidence of the temporary nerve injuries can reduce, but there is not a reduction, a significant reduction to the permanent nerve injury. So this means that if the nerve is placed in the wrong place, we can't reduce this kind of issue by looking at the X-ray, and also we can't reduce the incidence in case of high risk of temporary damage or permanent ones. So if the nerve is placed in a dangerous place, then we can absolutely reduce the risk, we can absolutely reduce the possibilities of having this kind of post-op consequence, but we can't avoid them completely. So this is important to explain during the informed consent to our patient. We can also make three-dimensional projects. We have the CBCT scan, which gives us the cutting of all the planes, but a 3D reconstruction like this can show us exactly how the nerve is going to appear in the surgery, and to see if there is correspondence and if the two structures are adjacent. And in this case, we also see a small bony vessel that we saw in the surgery actually. So this kind of 3D planning gives us a real good image of what we're going to find once we have our scalpel in our hands. Another kind of 3D planning is this kind of planning that shows us that there is a blocking, a duplication of the nerve. So there's a dual nerve, and also this can obviously gives us the difficulty of this kind of surgery. So now let's focus on the operational phases where we can try to avoid a nerve damage. And we see that this can happen in every phase of our surgery. And we will look at in detail on this kind, on these kind of phases. So we are going to have a problem with the anesthesia, with the incision, with the flap elevation, with the bony section, and with the socket curette, and in the stitches. What about the anesthesia? Well, the truncular anesthesion or full block anesthesion of the iron can give problems mainly to the lingual nerve, and this is the reason why you will see it in my surgeries. I perform a local anesthesia. I don't perform a full block anesthesia in the majority of cases. In my surgery, more or less 85 to 90% are performed with local anesthesia using articaine and a vasoconstrictor 1 to 100,000, and I avoid the usage of a fully block because in my 20-year experience I had a couple of temporary lingual nerve paresthesia, and so I reduced completely the usage of this kind of technique. These are some specifications of what kind of needle is best to use. This is also to reduce the breaking risk of the needle, which is very infrequent but may occur. Another thing, as I just told you, is that the literature with Moore shows us that following truncular or full block anesthesia, we can have the risk of paresthesia that varies from 1 to 160,000 to 1 to 4 million of injections. And we see that there is a major percentage of problems on the lingual nerve versus the ion or inferior alveolar nerve. And this is one of the reasons why I chose to reduce the full block nerve anesthesia. What kind of anesthetic should we use? Well, the literature shows us that mepivacaine, carbocaine, and lidocaine are the safest molecules to reduce the problems of paresthesia and temporary damage of the nerve. And we see in this graph that articaine has a peak in creating problems using a full block anesthesia with articaine. But this study may also have a bias due to the Weber effect or to the absence of evidence that was given in the previous years, where maybe the colleagues didn't inform the company about these problems with older molecules. So which anesthetic should we use? What concentration should we use? We should use concentration lower than 4%, so articaine 2%, mepivacaine 2%, or lidocaine 2%, and always aspirate before injecting the anesthesia. So always pull back the anesthesia to see that we are not in a vessel. This is very, very important. What about the flap design? We will look about it in detail when we talk about the technique, but just to say that we have to use a buccal approach or a buccal approach with the flap detachment and try to avoid the lingual approach. The buccal approach has much lower risk of lingual nerve, both temporary and permanent damage, and that the lingual part shouldn't be detached but just protected using a periosteum protector. What kind of incision should we do? Well, we usually do either a triangular flap or a trapezoidal flap or the envelope flap using a papilla preservation. We will look at it in detail in one of the next lessons. But an important thing is that the distal releasing incision shouldn't start more lingual than the sulcus that separates the buccal cuspids and the lingual cuspids, and we will look at that in detail later. What about the ostectomy? Well, the ostectomy provides and it's used to create an access to the tooth so that we have a cleavage point and we can create the odontosection, so the cutting of the tooth. we always have to try to do this on the buccal vestibular aspect and don't go on the lingual aspect. If we go on the lingual aspect, then we have to use instrumentation such as piezoelectric instrumentation that cut just the bony part and prevent lesions of the soft tissues. The approach is obviously mainly based on the Pellen-Gregory classification and on the Winter classification, and the CT scan allows small modification to reduce the transitory paresthesia. Obviously, we know that if the nerve is on the buccal side, we are going to do an ostectomy which is quite superficial, and we're not going to go inside towards the root where we can find the nerve. And for the odontosectioning, this is used to reduce the friction of the tooth on the bony aspect. So we are going to make different odontosections, different cuttings of the bone to reduce also the force that we have to apply to remove the tooth. And it is very important that odontosection is used to reduce the operative time, to reduce the surgical trauma, because we cut the tooth and we reduce the bone that we have to remove. So this leads to a better healing. And important aspect is that the odontosection should be performed incomplete. So always cut inside the tooth and don't perform a complete cutting of the tooth in order to avoid any risk of a nerve damage, especially on the lingual aspect of the tooth where we don't have any control. What about the socket revision and suture? Well, it is very important that if we have seen in our pre-op diagnosis that the nerve is in straight contact and in deep contact with the root, we know that after we remove the tooth, the nerve is going to be naked inside the alveolus, inside the socket. And so we know that we can't use a curette or a Lucas spoon to clean the area, because in that moment we can damage the nerve. So another important thing is, if there is a connection between the nerve which is exposed and doesn't have the bony canals, we have to try to reduce also the compression that the clot is going to create inside the socket in the first moment of the healing, and so maybe perform a secondary healing closure of our flap without giving a primary closure that can give a compression of the clot on the nerve. And another important thing is that since we don't know where the lingual nerve passes lingually to the second molar and to the socket that we have just created, extracting the tooth, we don't have to go too much apically on the lingual aspect when we go and place the suture on the lingual aspect, in order not to pinch the nerve itself. And what about the prognosis of these kind of lesions? Well, the iron paresthesia incidence varies from author to author, and there are many numbers in literature, but it goes between 0.35% to 8.4%, and that the permanent paresthesia occurs in less than 1% of these patients. But if the tooth is very intimate, very close to the iron, well, the percentages and the risk of percentages increase up to 20 to 35%, as in this paper. So we have to tell this information to the patient before we perform the surgery, in order to let them be informed and let their choice of having the surgery or not having the surgery be correct. What about the risk factors that are found in literature? Well, we know that over 24 years of age, the risk factors increase because the bone becomes denser, because the root becomes completely formed, and we don't have the incomplete formation of the root, which is a favorable moment where to extract the wisdom teeth. The literature gives us a major risk factor in the female gender, which is not explained, and obviously that the horizontal inclusion, which is a deeper inclusion, is a major risk factor, and that the closer contact with the iron is obviously a major risk factor, and also the learning curve experience, and so our skills is a very important risk factor. So we know that maybe applying the static classification, if we have a small experience, we have maybe to challenge the simple cases and avoid the moderate and complicated cases. So we have now an instrument to decide what kind of surgery we can afford to do. If we look at the post-op operative protocols, we're going to give some prescription for those surgeries that last long. So we're going to give an antibiotic therapy for those surgeries that last more than 30 to 45 minutes, but mostly if we have a bad exposure or enlarged exposure of the bone. We're going to give an analgesic therapy for at least 1 or 2 days, every 8 hours, depending on what drug we're going to give and subscribe to our patient, and then a disinfectant therapy with chlorhexidine 0.12% for at least 7 days until the patient removes the stitches. In case of a nervous lesion, we're going to give a corticosteroid therapy with prednisone 25 milligrams, 1 pill per day for 3 days to reduce the inflammation, and we're going to give a gastroprotector, ranitidine 115 milligrams, 1 pill per day for 5 days, and then we're going to give a neurotrophic drug. In this case, we give alpha-lipoic acid with a vitamin B complex for 1 month to 2 months, depending on how the patient goes on in the first period of recovery. And so we have looked on all the possible ways to prevent the nerve damage, and I will see you in the next lectures of the osteochrome channel of wisdom teeth removal. Thank you for your attention.